Welcome to today's Orton Family Foundation Heart and Soul Talk, Moving Past Triage, Real Solutions to the Opioid Epidemic in Rural America. Today's free webinar is presented in partnership with the Daily Yonder, a nonprofit publication devoted to covering rural America at dailyyonder.com. I'm your host, Fran Stoddard. On average, 130 Americans die every day from an opioid overdose, and rural America is harder hit by the epidemic. So what's being done to reverse this devastating trend? Today we'll talk to three leaders with very different vantage points who share the same goal to stop this epidemic. I'd like to welcome our guests. Ann Hazlett is a senior advisor for rural affairs at the White House Office of National Drug Control Policy. We're honored, Ann. Hi.
Hello.
And we also have Lisa Roberts. She's a public health nurse from Portsmouth, Ohio, which has been ground zero in the epidemic and has been on the front lines ever since the very beginning. Welcome, Lisa.
Thank you. I'm happy to be here.
And welcome too to Tina Stride, who channeled grief and loss into action in West Virginia by co-founding a group that gets people into treatment. Welcome, Lisa. Tina.
Thank you.
So, and a warm welcome to all of our participants today across North America and beyond for listening in. We use this Adobe Connect platform, allowing us to share our guests, a few visuals for you, and to take your questions. Be sure to click on that link to follow along if you're not with us already, and join our audio via your computer or your phone. We welcome the many advanced questions from over 400 registrants. I have combined similar questions, and we'll get to as many of them as possible. There will also be the opportunity to ask your questions during this talk. We'll stay alert to those coming into the participant chat box right below me and on your screen. This can also be a great place to share comments, resources, and ideas for everybody else. If you're having any technical problems, you can dial *0 for phone issues or email communications@orton.org. Those addresses are shown at the bottom left of your screen. So let's get on to our talk and our special guests. We're going to begin with an overview with Ann Hazlett, the Senior Advisor for Rural Affairs, again, from the White House's Office of National Drug Control Policy. An Indiana native, Ann has a deep and lifelong passion for rural America, small towns, and the people who call them home. Before joining the White House staff, she served as the Assistant to the Secretary for Rural Development at the USDA. There she led the Rural Development Mission to create an environment for rural prosperity. In this leadership role, she developed and led the department's response to the opioid crisis, including creating greater access to behavioral health care and housing for those in recovery in rural America. It's wonderful to have you with us, Ann. Go ahead.
Well, thank you. Good afternoon, everyone. Thank you so much for the opportunity to be part of a conversation about this issue that is so critical to the future of our country and particularly rural America. Very much appreciate the Orton Foundation's leadership in addressing this issue. I think while no corner of our country has been untouched by this epidemic, certainly rural communities have been particularly hard hit, from Alaska all the way to Maine. My own journey in this issue began back in 2014. That year, Scott County, which is a county in my home state of Indiana, and it's actually just a few hours east of Lisa's hometown of Portsmouth, Ohio, made national headlines with an HIV outbreak because of drug use. And in that town, Austin, Indiana, only about 4,200 people. Access to treatment and transportation and recovery services are very real challenges that this community is working incredibly hard to overcome. So when we fast forward 5 years later, Scott County is hardly alone. Between 1999 and 2015, drug-related deaths in rural counties jumped by over 300%. And last fall, Harvard University built on that trend, releasing a poll of rural Americans, which found that people living in rural areas identify drug addiction and economic opportunity as two of the greatest concerns they have in their communities and the future of these places. So with these numbers and these trends, we know that drug addiction is taking a monumental toll on small towns, both in terms of quality of life and economic opportunity. We look at the crisis and the impact that it's having, putting an enormous strain on already limited resources for emergency response, law enforcement, and social services. I saw this firsthand. Last year, I had gone to Boone County, West Virginia. This is a community just outside of Charleston, and I met a judge there named William Thompson. And in 2017, he had removed nearly 200 kids from their homes, and many of those cases had some tie to drugs, some connection to drug use in the home. And on the night that I met him, he had just been to a local church trying desperately to find foster families. At the time, he only had around 9 foster homes and about 200 kids that were in need of placement. So those are monumental challenges to work through. And we see our role in the Trump administration as really being a partner to those local leaders like Judge Thompson. And as we step up to partner, we understand not only that this issue is having such a big impact on rural communities, but I think as importantly, we know that rural places and the needs in these places, like a Boone County, look much different than they would in a big city. So we are focused really on ensuring that the needs of rural communities in addressing drug addiction are being elevated and met, which is the purpose of my role at the Office of National Drug Control Policy. In this office, our director is Jim Carroll. He is the President's Drug Czar. And our mission in this office is really to save lives. So in that mission, kind of our top priority is implementation of what's called the National Drug Control Strategy. And it has 3 lines of effort, if you will, to attack the addiction crisis head on. First, looking at how we can prevent drug use before it even begins. Secondly, how can we promote treatment and recovery services for those who are struggling with addiction right now? And then lastly, how do we reduce that availability of illicit drugs in this country? So my role then at ONDCP is how do we take that strategy and ensure that as it's implemented, the needs of rural communities are met? We're doing that really through 3 priorities. Our first priority is building more infrastructure for prevention, for treatment, and recovery in rural communities. When we look at those needs in rural areas, we first start looking at what are some of those critical assets that we have to build strong and healthy communities. And we look at rural areas and we know there are some significant gaps. So some of the gaps that are quite a focus for us right now are first looking at drug court and alternative docket management strategies that have been very effective in urban areas. There's some of that being used in rural places, but we think there can be more of that. So that's a priority for us. Secondly, how do we increase access to treatment and recovery support? In some places, those facilities can be located in a rural area, but where that's not possible, how can we do more things through telemedicine and mobile service delivery? And then lastly, the need for transitional housing. This is an issue in all communities across the country and certainly in rural areas. In addition to those critical assets, we are focused on what tools local leaders need to build these grassroots solutions at a community level. We built a number of tools last year that I want to make sure the listeners and the viewers have access to. There's a slide that will be coming up to show some links to those tools. First, we built a federal rural resource guide last year that is really a comprehensive overview of all of the programs that are out there in the federal family, to different departments and agencies to meet some of these needs in rural areas. Secondly, we built a community assessment tool where local leaders can go on and see data about what's happening in their community around overdose deaths and look at that data overlaid with data about some of the things that might be driving those conditions in their community. Factors like education levels, poverty, unemployment rates, and all of that is available free on this website. And then lastly, we built an opioids resource webpage as part of the Department of Agriculture's website because we want to be able to share information with our partners. So as we're building off of that momentum, we want to disseminate these tools more widely into rural areas, and then importantly are developing some new tools. We are currently working on a community action guide that will be released in the near future, as well as an economic impact study and an interactive resource website. So in addition to infrastructure, we are quite focused on facilitating greater partnerships that will help strengthen the rural response. We know that both in the government and the rural stakeholder organization community, there's a lot of work going on this issue, so making sure that some of those efforts are better coordinated is a high priority for us. Last year, Director Carroll on the government side created a federal rural opioids work group, and this brought together departments and agencies from across the federal family, all to look at how we can better coordinate programs and policy around some of these rural needs. So we are now building off of that momentum and looking at some of the targeted partnerships that we can forge around issues like transitional housing and jail-based treatment systems. Outside of government, here in D.C., we host a monthly Rural Partners meeting. It includes everyone from the National Association of Counties to the sheriffs to the Farm Bureau. This is a very important venue, really, for information sharing and relationship building between rural interests. So we want to build on the stakeholders that are part of that conversation. And then in addition, going forward, we are particularly focused on working more closely with the philanthropic community. We know there are so many foundations already working in rural areas, and how can we better harness that power to address this specific issue? And lastly, we have infrastructure, we have these partnerships, and then looking at innovation. How can we drive innovation in local community action? We know no two rural places are the same, but what might be working in one place, we want to be able to lift up in another. So last year, we held or were participants in over 20 roundtables, rural roundtables in over 20 different states. We are taking all of the lessons that we have learned from those conversations and putting them into this community action guide that I mentioned. We are also taking that information and putting it on an interactive model practice map that's on that Rural Opioids webpage. As we build off of that work now, we have several focuses for innovation. First, how can we help rural employers work on this issue to employ people coming out of treatment and in long-term recovery? Secondly, how can we better engage the faith-based community around this issue? And then lastly, and this perhaps is where I should have started, the need for greater capacity at that community level to be able to know what's needed in their town and then apply for those grants and loan programs that are out there to meet those needs. So with that, I want to close, I guess, with a simple thought and then look forward to the questions and the dialogue. And that thought is this. I know that in the course of my work on this issue, I'm often asked, so what is the answer to this crisis? And when I get that question, I think back to the wisdom of author Sam Quinones, who wrote the book Dreamland and has spent a great deal of time with Lisa, who you're going to hear from shortly, and other local leaders in Portsmouth. And in Sam's words, the antidote to addiction is community. So when I step back and I think about my travels, whether it's my home state of Indiana or Washington State, I've seen this firsthand. If there's any silver lining in this crisis, I believe that it has become a catalyst to become a tipping point, if you will, for broader change in places like Scott County. It's brought local leaders to come together in a new and a more collaborative way to tackle some of these underlying drivers that we have at the root of this epidemic, things like the need for better infrastructure, transportation, workforce training in these communities. So as all of us are rural leaders and advocates, I see a huge opportunity in this crisis to build places of hope and opportunity for the future. So with that, I will turn it back and simply say that I very much look forward to working together to build strong and healthy communities now and for generations to come. Thank you.
Thank you so much, Anne, for being with us today. That shapes a lot of things, and it's so exciting to hear how much is happening on your end. We'd now like to hear from Lisa Roberts. She is a registered nurse with the Portsmouth City Health Department in South Central Ohio, one of the country's early opioid misuse hotspots. Lisa has been on the front lines working extensively in the area of opioid misuse, overprescribing, and overdose prevention locally and nationally. Among her accomplishments, Lisa helped form the Scioto County Drug Action Team Alliance and assisted in getting the county a high-intensity drug trafficking area designation. She also secured a drug-free community support program grant, and she initiated Ohio's first community-based naloxone or Narcan distribution program that has been widely replicated throughout the state and saved thousands of lives. Lisa, it's fabulous to have you here. Go ahead and with your presentation. Thank you.
Okay. Thank you. I must apologize. I haven't moved enough and my lights have gone out, so I may have to get up and wave my hands here in a minute. But well, welcome everyone. I'm going to talk just a little bit, orient you about Scioto County. We are an Appalachian rural county that's located at the very bottom of Ohio, and we actually border Kentucky and West Virginia. And we have long had economic hardship. We're actually an Appalachian distressed county, which means that we're predominantly poor, very rural. And so we certainly had some geographic vulnerabilities related to the opioid epidemic. And so but over the course of the last 20 years, we actually had become the home to some major criminal operations, overprescribers. We were the location of the leading prescriber of oxycodone in the nation 3 different times. And these places just became kind of like criminal enterprises, which Sam Quinones details in the book Dreamland quite a bit. And so in 2010, Scioto County became the first county in the nation to declare a public health emergency related to prescription opioids. At that time, we actually had big, huge signs outside town that kind of advertised these pain management clinics. And we had 9.7 million prescription pain pills distributed in our county in 2010, which was by far the highest in Ohio. We found ourselves in 2010 with the highest fatal overdose rate in the state of Ohio, the highest opioid addiction rate in Ohio, the highest rate of neonatal abstinence syndrome, the highest rate of drug incarcerations, and also we had seen just an enormous increase in hepatitis C. So I want to talk a little bit about what we've done over the course of the last 9 years. But just so that we can kind of see our location here in 2002, we were located very close to one of the original hot spots for fatal drug overdose in the United States. And over a 14-year span, you can see how this epidemic has truly just spread across the country, rather behaving like a communicable disease spread. And so the United States basically has seen 3 major waves of fatalities related to opioids. It began with prescription opioids, and then efforts to control the amount of prescription opioids led to a major influx of heroin beginning somewhere around 2013. But now we've actually seen this analog fentanyl drug just become such a problem in the United States that it's driven the overdose fatality rate way up, and that's the highest line you see. So our county first formed a coalition in 2010, and then we were lucky enough in 2012 to get some federal assistance from the Office of National Drug Control Policy. And this was really a game changer, I believe, for Scioto County. We got our first drug-free community support program from the Office of National Drug Control Policy, and we also got a high-intensity drug trafficking area designation by Congress in that same year. And so we underwent some strategic planning, and we came up with 3 major strategies. First, to prevent new initiates to opioid abuse. Second, to reduce the harms associated with opioid use disorders, including death, disease, and crime. And then, of course, to treat all of the people that had become addicted along the way. So I'm going to talk a little bit about some of these strategies. Preventing new initiates to opioid abuse is always going to be important because it's an upstream approach. If you continue to create addicted people indefinitely, you never get out of that situation. So we worked on improving opioid prescribing, and Ohio actually passed some opioid prescribing guidelines, increasing the use of our prescription monitoring programs, and we established major drug take-back opportunities, including the typical drug take-back days, but also permanent drug drop boxes at multiple locations throughout town and the county throughout the year that can be utilized anytime. So one of the outcomes that we saw from that was that we had the largest reduction in prescription opioid consumption in the state of Ohio. And so we have actually seen about a 46% decrease in the amount of opioid pills prescribed, and we've seen a 62% decrease in the strength of those pills. And so we definitely had major outcomes in terms of reducing prescription opioids. One of the biggest important things that we did see from that was we decreased accessibility. And so this is some surveys over the course of a 6-year period of our teenagers, adolescents, and their past 30-day drug use. And so we had the largest reduction in past 30-day drug use among our adolescents in Scioto County was it was in the non-medical use of prescription drugs, and that was a 41% reduction. Number 2, reduce the harms associated with opioid use disorders. We piloted Ohio's first community-based naloxone program. We actually named it Project Dawn. Stands for Deaths Avoided with Naloxone. We had major public awareness campaigns around this. We had to work with the legislature to pass laws that would make Narcan more accessible and easy to obtain. And we were able to get corporate protocols established at major pharmacy chains so that people can just go in and ask for Narcan and have it covered as a pharmacy benefit without a prescription. We also got a Good Samaritan law passed in Ohio that really kind of takes away the fear of calling and reporting an overdose, and also provides civil protection for anyone who responds to an overdose, regardless of the outcome, and uses Narcan. So the result of that is that, we just had thousands of lives saved across Ohio, and lots of people carry Narcan in our county now. We also really kind of tried to target at some hot spots in our county, and so we have one area of the community that is particularly hard hit in terms of overdoses and drug use, and it's a former industrial place where people tended to work that worked in factories, and the factories have long gone, and so these people are typically kind of impoverished. Drug use is very common. We actually partnered with a carry-out in that community that's kind of like the community hub for our Overdose Awareness Day. Unfortunately, we're one of the counties, too, that have been named by the Centers for Disease Control as being at risk for an HIV outbreak. Like Ann mentioned, in Scott County, we're very close to Scott County, Indiana. And so we have had to take action on that. Our hepatitis C rates were about 5 times the state average in 2010, and so we did begin Ohio's first rural syringe exchange program in 2011. We did work with the state legislature to get some of those laws changed to make it easier for syringe exchange programs to operate in rural counties. And we currently have over 1,000 participants in our program. They are predominantly opioid addicted, dependent people, and we recently began distributing fentanyl test strips through this program so that people could identify the presence of that analog fentanyl in drugs. We actually have someone embedded in that program that can do HIV testing, and also someone embedded in that program that can assist those people immediately to access addiction treatment. And as a result, outcomes from our bloodborne pathogen prevention program, we've actually seen a reduction in hepatitis C, and we're no longer #1 in the state, yay. And we have seen major reductions in the incidence of HIV. So we're keeping a really close eye on that because we certainly don't want to have that happen here. We've also used our syringe exchange program to increase the availability of Narcan in this high-risk population. And so we typically have Narcan available in our program and give a lot of it out through the syringe exchange program. So we're currently at 75% of our people in the syringe exchange program carry Narcan, and they use it quite a bit. Strategy 3, treat the addicted. Boy, we worked really hard on this, and we have had tremendous success in this area, I believe, for a rural county. We established a local detox crisis unit in 2014. Our hospital actually opened a medical stabilization unit for 3 days to get people stable enough to go into addiction treatment. We conducted trainings with prescribers, and we're able to double our DATA 2000 waivered prescribers, which is a requirement for someone to prescribe buprenorphine for opioid use disorder. We also are in the process of getting a SAMHSA certified opiate treatment practice, and we are probably a couple of weeks away from having access to methadone in Scioto County, which has been a bit of a struggle, but will be a tremendous accomplishment for us. Established 4 drug courts, and we established overdose response teams to respond to the emergency department for people who survive an overdose. And within our agency here at the Portsmouth City Health Department, we underwent alcohol and drug certification, which is through the Department of Mental Health and Addiction Services, which allowed us to begin doing addiction treatment ourselves. And so with the help of a HRSA grant, Rural Health Opioid Program, we were actually able to establish a hub and spoke model here at our health department, where we actually serve as the hub for anyone who is addicted, that we can assist them at the moment and get them right into addiction treatment, spoke them out to appropriate services. And our health commissioner was so inspired that he actually became board certified in addiction treatment. So, and okay, and so that's all I have, and I'm sorry, but I'm going to get up and wave my arms and make my lights come back on.
Okay. Lisa, thank you so much. This is such rich information, and many of the questions people have been asking. I'd like to turn now to Tina Stride. She is founded the Hope Dealer Project in Martinsburg, West Virginia in 2015, along with 3 other women, to fill the void they saw in treatment and recovery services to reverse the effects of the opioid epidemic in their community. Tina, whose son struggled with opioid addiction, plays an active role in serving those combating addiction by connecting them to resources to overcome addiction from treatment through recovery, including life skills, therapy, and cutting through the red tape of insurance. She may drive sickened addicts as far as 6 hours to get a detox bed. Stride and her co-founders were recognized this past year on People Magazine's list of 25 women changing the world. Congratulations, Tina, and thank you so much for sharing your story with us today. Go ahead.
Thank you. And I do want to say thank you for doing this. I think these need to happen more and more every day. Our community where I live is in Berkeley County, West Virginia. We're on the eastern side of the state. The closest detox center to us is 2.5 hours away. But let me tell you a little bit more. I got ahead of myself. Let me tell you a little bit more of the Hope Dealer Project. Yes, it's 3 moms. Myself, Lisa Melcher, who is our CEO, and Tara Mason, who is the vice president. I'll give you a little bit of our history. Lisa had a daughter, Christina, who has been battling addiction for about 10 years. We had Christina in a program, and she was 78 days clean. Christina walked out of her program and said, "Let me do it one more time." We lost her in May of 2017. Myself, I have a son who is 28 years old who has been battling this for about 9 years. I get very emotional when I talk about my son. He has been through treatments about 5 times, has had many relapses. His last relapse, he overdosed here in my house. I almost lost him that night. my son reached back out and said, Mom, help me again. I got to get this right. So my son is now almost 9 months clean. Praise God for that. Tara, my vice president, was dating a gentleman and was her fiance who dealt with addiction. As of today, he is now clean. So us 3 moms, we met in what's called Nar-Anon. This is a meeting for parents or family members, friends that get together and we talk about how do we deal with a loved one that's in addiction and how can we get stronger on our side as the family. So we met there the first night, didn't even know each other. Our town was dying. My son's generation, half of his generation is gone. So we said, what can we do? So we came together and said we're going to create this program. It's called the Hope Dealer Project. And it's ironic because Lisa and her daughter had came up with the name a year before when Lisa lost her son-in-law to a heroin overdose. So the name stuck, and we said, okay, now what are we going to do with it? So in our state, we do have detoxes and rehabs, but nowhere around us. So our addicts, when they reached out for help, were told no, or we can find you a place, but find your way to get there. It didn't happen. So they would go back out and use again. So we said we're gonna figure this out and we're gonna find out how to make this work. So when an addict reaches out to us, we have Facebook page, we have an 800 number that's active 24/7. Word of mouth on the street has been crazy. When they reach out to us, we first have to find out what type of insurance do you have. If you have private insurance, we have teamed up with rehabs and detox centers around the country that we can have them on a plane in 6 hours. If you have Medicaid, there's a lot of red tape. We had to learn the system. If you have Medicaid, you have to get medically cleared, which means you have to go to the ER. That's a process in itself, and it takes hours. The longest I've sat in the ER with a client of ours was 7 hours. With a dope sick addict, 7 hours is an awful, awful long time. So then I would tell the hospital, I'm taking them to the detox center. As soon as we would get done, I'd contact the detox center, let them know we were on our way, and they were there within 2 hours to 6 hours. If someone doesn't have any insurance, we work with them to get it. We have them go onto our site to apply for Medicaid, and we work with our DHHR program here in Martinsburg, and they pull the applications for us and help them get insurance as fast as they can. Those we're afraid of because it's going to take 2, 3, 4 days before they get approved. And if anyone has ever dealt with an active addict, they know when they reach out for help, you have to jump on it right now. They get dope sick. So that's where the Hope Dealers came in. We hold their hands. We talk to families. I have spoke at churches. I have spoke to children in schools to explain what it is, how it is. Please don't use it, and these are the effects that you have if you do use it. There was a point when my son had overdosed that, I cried, and I said, why am I doing this? I can't even save my own son. And my son looked at me that night, and he said, Mom, there's more of me out there, and we need you, and we need the rest of the 2 Hope Dealers. You guys help us get help. So please, Mom, keep doing what you're doing. So we push forward every day. The Hope Dealers, we survive just by getting donations. We don't know how to write grants. We don't know what grants to go after because what we do is so unique. So the donations have come across the United States. We were interviewed by CBS after I had spoken in Washington, D.C., and CBS put us on their morning news. We got donations from across the United States. I tell all of our active addicts here when they reach out, it's not just me that's standing here beside you to get you in recovery. It's the whole nation. People want them to get help. So I'm going to cut this short to give it time for questions and answers because I know there's a lot. I just want to say, this is our saying as the hope dealers. We're the new dealers in town. We deal hope. And there you go, Fran.
Tina, thank you so much. It's such an inspiration what you are doing, and thank you. I'm sure you inspired many people on this call today. So thank you for your story.
Thank you.
So lots of questions came in. I'll do the best to get a number of them out. I'm gonna go back to Ann for there are a number of questions from Missouri, from Louisville, Kentucky, from Pennsylvania about underlying and root causes. From Missouri, 65% of the addicts in St. Louis are related to legally authorized prescriptions. So I know that there are many underlying root causes, but can you just talk a little bit about paths to prevention, looking at the root causes of this epidemic?
Sure. I think when we're talking about rural communities, I appreciate the reference you made to prescribing, and that has absolutely been a focus, not just in rural, but in urban areas as well, as working with doctors and dentists and looking at prescribing practices. And that's an area that we do feel good about the numbers we're seeing and the trends with prescribing numbers being down. But when you talk about rural, I think the first place I would start when I think about an upstream driver is infrastructure. There are a lot of places that do not have robust modern infrastructure, particularly lack of access to broadband connectivity, and the impact that that has on economic opportunity, so creating hope for people living in these places that may be young and want to grow up and have a career in an area. It affects our education system. It affects the type of health care that somebody has access to, and so infrastructure is absolutely a critical piece of this. There are a number of programs specific to rural broadband. There's one at the Department of Agriculture right now for broadband resources, and again, all of that would be captured in that federal rural resource guide that I mentioned. In addition to the infrastructure piece, I think we can step back and look at, in many rural areas, the lack of access to quality health care that is there, particularly around rural mental health. And in many cases, there is a close connection between addiction and a broader underlying need for mental health services. And there can often be stigma about getting access to those resources if they are there. And then, the infrastructure, the healthcare access, then economic opportunity is deeply linked with both of that. But certainly, that those are all issues that I think when you combine them can create a scenario that can be a perfect storm, if you will, in many rural towns.
Great. So strengthening the economic base is also going to help if that's possible.
Yes.
Yeah. A number of questions about recovery. I'm going to go to Lisa. And a number of people are saying, are there other drug approaches to pain relief? Chiropractic, acupuncture, massage, feedback, these alternate methods to chronic pain, or even recovery coaches that some people use. Do you have some response to that? Not that that's only, but are those other alternatives that people can look at instead of going to opiates?
Yeah, I think that, the country's kind of realized that there was a little bit of misunderstanding about the harm and the addictive qualities of opioids that began to, the shift in the way that doctors prescribed them happened in the mid-1990s. And so, it became rather apparent that they did carry some high risk for addiction and also weren't quite as good at pain relief as they were originally thought to be. And so with that, I know that there's our local providers at hospitals have looked at different types of pain management that don't utilize opioids. And there's some significant effort within the federal government to come up with pain relief medications that are non-opioid and non-addictive. As far as the recovery coaches, yeah, we certainly have. Ohio actually made recovery support a billable service, and so there was a real effort to train and certify these peer support specialists to kind of augment that recovery piece and help people stay in recovery. And so we've certainly utilized that. In fact, our overdose response team is made up of peer recovery support.
Fantastic. And another piece is reaching rural people. And Tina, you certainly do this. Somebody talks about, our treatment centers are an hour or plus drive away, and you've driven people 6 hours. So sometimes that you just have to kick in and find a way to get there. So people are looking, how do you suggest reaching rural people? And we've heard about broadband is important. When resources are limited, how do you get them to resources? How do you get them to housing and transportation, education? So, Tina, some thoughts, because you've seen the barriers and you've jumped and leaped over them. People are talking about barriers from California, Pennsylvania, Maine, South Carolina, Colorado. What's amazing is these people are all over and they're all looking for the same kinds of answers. How would you say how you reached people and helped them?
Well, like I said, it's a lot of it is word of mouth. We have helped so many on the streets that have reached out. Their families heard me speak or saw us on Facebook, and the word of mouth is we have business cards. Tara is famous for walking through our street and just handing them out to people. So that is one way that they reach out to us. I can say that because of the Hope Dealers, and I'm not taking the praise for what we do because we're just a very little piece of it. Because of us speaking out and saying that our area is, the closest is 2.5 hours away, I can say a drug counselor here in Martinsburg opened a detox center. We now have one that is 5 minutes away, which is beautiful. It's a 16-bed facility. And we were notified that we are getting a rehab built by federal money. It's going to be a 48-day bed program. That is huge for this area. My thing is the communities have got to stop being in the dark about this. This affects from the richest to the poorest person and the families. I ask family members, don't stay in the dark. Don't not talk about it anymore. Please speak. Let it be known. If you have an active addict, talk recovery. Tell them there is hope for them to get better. All they have to do is reach out and look for it.
So that takes me a couple of questions. Steph from Colorado talks about what's a suggestion for a small rural mountain town with no to limited funds in addressing this topic. And then she says the town doesn't publicly talk about it, as if it's not an issue. And we also from New Jersey, Texas, North Carolina are also talking about we can get it in the schools, but it's not in the community. How can we really begin to talk about this more and advocate about youth? Let me see, either Lisa or Ann, some ideas about, Ann, I see you nodding first. I know you both can answer this, but how can we make sure that the education is out there and people actually do talk about it, as Tina suggests, and people don't back away from this problem?
Right. Well, I appreciate the question, and I appreciate what Tina has done and being willing to share her story along with other moms. I think that's where so much of this begins. I might step back. I think there was a very appropriate perspective raised that people may feel comfortable talking about kids and getting in schools, but once it goes beyond that, that can make folks uncomfortable, especially in a rural area. Let me talk just briefly, I guess, about two specific examples I've seen where they've harnessed, if you will, a asset that's in many rural communities to kind of drive that conversation. Many communities have, a Rotary that's often kind of a heartbeat of a small town. I was in rural Maryland last year where the Rotary and the Sheriff and the Community Foundation have tackled this issue. They've started a campaign called Talbot Goes Purple, and they're using the color purple throughout the town to raise awareness about substance misuse. Just getting that color out, and some of the community roundtables that have been held have made families feel comfortable to come forward and start sharing their story. So it's really been community assets coming together and launching this off as in a collective manner. Another example that I've seen that I want to highlight just briefly was in western Pennsylvania in Crawford County, I believe. There, the hospital, Meadville Community Hospital Foundation, has really led the way in driving a community conversation. They have a campaign called Let's Talk. It highlights a lot of local stories, and I think, again, that's an example of an asset that's in many rural places that is a trusted leader, if you will. And so when they take that pulpit and go with it, I think it gives permission for people to step forward and share what might be happening in their families. And then that gets people towards treatment.
Okay, anyway, just do it. Get out there. A number of people wrote in about methamphetamine. And Lisa, this is still a real problem, and they're saying it seems like this is the conversation isn't about meth anymore, but meth is a real problem, and we still have it in our community. Are there any resources for help there? Lisa, some thoughts about meth.
Well, I have to say that methamphetamine has become a big problem here now as well. Through our syringe exchange program, we're able to kind of monitor drug use trends. And so we have been seeing methamphetamine, in particular a drug called ice, that is a Mexican manufactured type of methamphetamine, really just be so easily accessible, and it's basically just being brought in here like crazy. And so, a lot of people seem to be saying that they're switching from opioids to methamphetamine now because they're afraid of the analog fentanyl, which is is pretty much predominant in our local heroin supply. And so part of that may be driven by people that are trying to at least use safer alternatives to drugs. But historically, I learned this from someone in the Drug Enforcement Administration at the National RX and Heroin Summit. Historically, an amphetamine epidemic always follows an opioid epidemic. And so I think that we are going to be seeing methamphetamine certainly become more of a problem. And, one of the really kind of bad things about that is that, methamphetamine treatment for methamphetamine addiction is a little more difficult. There aren't medications to treat it typically. And so, it's still really important to get upstream and try to prevent people from using, methamphetamine in the first place. And supply reduction. I can tell you that every single person that we've surveyed over the course of the last few months, and there's been over 100, has said that methamphetamine ice is just next door. I mean, it's that accessible. So there is vast quantities of this coming into our country right now.
Wow.
And Fran?
Yes, go ahead, Tina.
This is Tina. Another thing that we're noticing too in this area is Molly. It's called Molly. What it is, it's a synthetic drug. So the normal drug tests don't pick it up. And I just want to, because I don't want it to feel like we're bashing the addicts, because they're the ones that we're here for. The thing I want people to remember is the addicts, the active addicts, find ways of not to be sick. I don't know if people truly understand it unless you actually see someone go through withdrawal. They are sick, and it goes through stages. And I know my son told me, Mom, I used just to stay well until he got clean. So I don't want to make excuses for what they do, but I want people to understand, too, the thing we need to stop doing is stop judging them. We need to reach out to them and offer them help. And we need to say it over and over and over to them And one day it will click. One day they're going to say, you keep telling me you can get me help, so do it today. So that is the talk that the hope dealers have too. You may not want it today, but there's help out there. Just let me know when you want it because we're going to get you there. And we need people to step up when they do reach out. I have a young man right now, and I'll make this fast, Brian, I promise. I have a young man right now who knows he has tried to stay clean by using nothing. He can't. He has to be on Suboxone. Well, we have Suboxone programs here. 2 weeks ago, he reached out to us and said, help me get into one. The waiting list is a month long. He cannot get into that program for a month, but he wants to be clean today. So myself and this young man has been going through hoops because I am one person that will not take no. I will find you a way to get you to stay clean. So we found another state. I'm paying money out of my own pocket to get his Suboxone for him, but it's legal. He's doing it the right way until we can get him into a program here in West Virginia so his Medicaid will cover it. Those are the issues that our active addicts run against. And that's why so many of them go back out. Some of the systems are broken, and we need to figure out how can we fix them. Because we're talking about my son's life.
I know that, yeah, go ahead, Lisa.
I wanted to mention something that I don't think we've talked about yet, and this is a good time, but, you know, the Data 2000 waiver, just in the past couple of years, federal law expanded to where nurse practitioners and physician assistants can now prescribe, and they also raised the federal cap. And so, you know, communities can do things. We had trainings where at one training we trained 33 new Data 2000 waiver buprenorphine prescribers, because we had waiting lists just like you're talking about, Tina. And that helped us dramatically, especially when the federal cap was raised and allowed new people to prescribe. But the other thing that we have not mentioned here is telemedicine. And telemedicine is something that can be really important to rural communities because the physician prescriber can be in California, you know, and so there are those options available where maybe if you can't get someone to actually, you know, prescribe locally, you could get someone to, you know, work with a provider that could do telemedicine in your county.
Can you please share that information? I didn't even know that existed.
That would be great, and I know that Ann has also said that she will follow up on many of the questions that we're seeing in the participant chat. She will follow up, and I'm sure Lisa and Tina will also follow up on some of the questions we might not make. But Ann, did you have something to quickly add?
Yeah, I definitely want to echo Lisa's point about telemedicine, and we do have a lot of resources for that, so would love to help get anyone going back to what I was saying about infrastructure, if you're in a very remote area, I think about a county I was in last fall that was one of the hardest hit counties in the country, and my phone was on emergency service the entire time I was in the county. So before, you know, we need that broadband to help fuel the telemedicine, but if you are looking for resources either for the broadband or for the telemedicine, we would love to help you get connected to the dollars that are there at the federal level for that. I also just want to make a comment on the meth side. We are hearing both in travels and conversations here with people, hear that all over the country, the way meth is, the use is exploding. And I think we're doing a lot of planning here about how to help local communities respond to that, but it only re-emphasizes for us that we have to create a structure that is not specific just for one drug. We need to plan for something that will be here today and for drug trends that may come in the future.
Right. One thing that from Michigan to Tennessee, Iowa, Pennsylvania, California, they're talking about some criminal justice issues. Basically, in rural America, they feel that the only way they can deal with this is to make arrests and put people in jail, and that, you know, that's where they detox and dry out. And They're kind of asking, and in Michigan, in Tennessee, we're building new jails for drug-related crimes. Are there other options? What is the criminal justice? Where does it fit in? Are there other options? And I'm going to start with Ann, just with that question.
Absolutely. I appreciate you raising that. When I mentioned some of our priorities, one that I talked about were drug courts infrastructure as well as alternative docket management, which is a fancy term that the staff here have taught me about. It's basically something that's a little less than a drug court, but helps you deal with people who have this challenge in a more structured way to help get them on a road to prosperity and to health. One of the things that we have seen in working with rural judges and sheriffs there are those folks that want to do something differently. They, even those that have been in this service for a long time, understand that this is an epidemic that we're not going to arrest our way out of, and building a bigger jail or a new jail is doing things the same old way. And so we have found that when some of these folks that want to try something different are in a rural area, going to some conference that's a lot of their big city peers is not helpful, because it's apples and oranges about what they face in a small remote area. So what we have been doing is to find, and I think this could be done at a state level as well, we're doing it at a federal level, working with the Department of Justice, basically to find those rural judges and sheriffs that do have a model that's working and to create a peer-to-peer network. We held a workshop in December, and we just held one last month in Ohio, where we brought together 5 or 6 different culturally and geographically similar states, bringing 5 judges and sheriffs from each state together and having a 2-day workshop about what some of those alternatives might look like, and then having them hear from somebody that is in their type of role about what worked and what didn't work, and just getting that peer-to-peer conversation going, I think, is where a lot of this begins. And if anybody's interested in doing that at their state level, we are more than happy to give you some thoughts on what we've seen and to connect you with some judges that are doing this and doing it well.
I'm reading a lot about people wanting to do regional coalitions. I know, Lisa, you've worked with a number of different counties, people pulling together 14 counties in Tennessee, but they want some federal help, and they'll probably be writing you, Ann. It sounds like people are doing this kind of work. We're almost out of time, so I just want to make sure that we give each of you some last-minute thoughts. And a woman from Sharpsville, Pennsylvania, I think, has the best question around this. What efforts have made the most significant impact on opiate use in your area? And maybe especially some efforts that people can get out and work on right away, can just dig their heels in and go for. And if it's repetitive, that's fine, but let's hear from you. I think I'll do it the opposite way that we began and start with Tina. What would you say to people who are like, what's the most significant thing I can do?
Well, the biggest thing is stop tearing the addicts down for them being addicts. Remember, they are somebody's child. I don't care if they've been Narcan, which is the medicine that brings them back from overdoses, 20 times. That one time could be what saves their life. So start talking about it. Stop keeping it in the dark. I tell every family, don't be ashamed. There is help out here, and let us help you. So stop being ashamed. Okay, addicts, reach out. There's help.
Yes, exactly. Fantastic. Thank you so much, Tina. And Lisa, your thoughts.
Oh, my lights went out again.
Here we go.
Yeah, I've learned. There is no silver bullet to this. No, it's going to be a lot of different things that you do in the community. So the one thing that I would say is community collaboration, because all of these things have to take place across systems that are governed by so many different people, that in order for them to work, you have to have buy-in from law enforcement, healthcare providers, treatment providers, people in recovery. And so that's why a coalition is so important, I believe. So I think that's probably the one thing I would say, is start a coalition and start working together.
Fantastic. And I just want to bring up, before we get to Ann, Amy from Concordia, Missouri, is reaching out to any of you. She said, are you aware of working entities in small towns, say under 5,000 people, that have had success in helping to turn back the crisis? Are there ways for other communities or groups to reach out and partner with successful entities so they don't have to start from scratch or reinvent the wheel? So we know we have a lot of wisdom on this call. Get into presenter chat, and if you're willing to partner with Amy or Missouri, that would probably be awesome. I'm sure there are other people that, not presenter chat, your participant chat, that would be very helpful. Work together. So Ann, your final thoughts on what's making the most significant impact now, and how can people start on that road?
Yeah, let me touch just briefly on the question from Missouri. We certainly, in our own travels and all of the different people that have been so blessed to meet in this work, have a lot of insight into what we've seen working in other communities. That's going to be the heart of this community action guide that I mentioned, but I would love to connect with you and see if there's a specific thing that you're interested in tackling, and see if we can help partner you to somebody that is already doing that or might have some of that foundation built. I think, what is working to me, it's hard to be original here. I couldn't agree more with what Tina and Lisa have both shared. First, going to Tina's point, I think the way people treat people in their community that are struggling with this issue goes to that broader need to address the challenge of stigma. And what I've seen is that when stigma is dealt with, whether it's a family that's willing to share their story or community like the hospital that I mentioned in Western Pennsylvania that's created a structure to have that community conversation, once that barrier of stigma goes away, so many things change. It changes for the individual that's living in that community, but I think as important as that individual, the whole community conversation changes. It brings different people to the table. And to Lisa's point about this isn't just one thing, it's a lot of little things. Those little things take everyone from the judge to the business community, to the faith-based community, to the schools. It takes everyone working together at one table. And while I don't want to minimize the impact and the darkness of this issue on our small towns, what I've also seen is there are many issues, those upstream drivers, that need to be addressed regardless of the drugs in the first place if we want these to be places of hope and prosperity 3 and 4 generations from now. And if drugs is what it takes to get people to the table to begin that conversation, there's going to be stronger communities coming out of this in the end. And that's what keeps me working on this every day, and really just am thrilled to be able to be part of this conversation today and some of the networks that will be built from it. So thank you.
Thank you so much. Ann Hazlett, Lisa Roberts, Tina Stride, you are heroes. Thank you for so much that you're doing for rural America today. Thank you all for joining us.
Thank you.
And I also want to thank the Orton Family Foundation, who made these sessions possible, and to our partner on this webinar, Daily Yonder, a nonprofit publication focused on rural America at dailyyonder.com. Thank you all for joining us today and listening and joining in. We encourage you to please take a moment to fill out the short survey provided at the link on your screen so we can make these calls the most relevant to you. A recording of this webinar will be sent around to all registrants and will be posted on our website at orton.org in the next few days. There's so much potent information here. I hope that you all use it. Thanks for joining us and for your interest in strengthening rural America. For the Orton Family Foundation, I'm Fran Stoddard. See you all next time. Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Oh.
Yeah, great job.
I got to run to a call.
Okay.
Good job. Okay. Pretty good.
The meeting is now over. All the participants have been disconnected.